Hello and welcome to the Women's Health Board Review. I'm Dr. Catherine Rexroad. I'm Chief of the Division of Women's Health at Brigham and Women's Hospital in the Department of Medicine, and I'm an Associate Professor of Medicine at Harvard Medical School. I have no disclosures. So we're going to start right in with a case. A 32-year-old woman, G1P1, comes in for a visit and she's 6 months postpartum. She's fatigued and has lost a few of the 30 pounds she gained during pregnancy. She takes a multivitamin, no other medications. And on physical exam, her weight is 150 pounds, height 5'2", and her thyroid feels slightly enlarged without nodules and is non-tender. Her CBC is normal, and her TSH is 24. So which of the following are true or is true? Choose one. Subacute thyroiditis is the most likely diagnosis. This condition is likely to recur in subsequent pregnancies. TPO antibodies are likely to be negative. You should wait for spontaneous resolution rather than treating with thyroxine. I'll give you just a moment to choose. And the correct answer is this condition is likely to recur in subsequent pregnancies. And we'll talk about why each of these other choices is not true. So if you think back to the discussion earlier in our section, this patient pretty clearly has postpartum thyroiditis, which is a variant of autoimmune thyroiditis characterized by 3 phases. The initial hyperthyroid phase within 6 months postpartum and lasting up to 2 months due to leakage of thyroid hormone from an inflamed thyroid gland. This is followed by a hypothyroid phase, typically up to 10 months postpartum and lasting 3 to 6 months, and then in most cases, a return to euthyroidism. So the patient that we see who is about 6 months postpartum is in this hypothyroid phase with an elevated TSH. TPO antibodies are characteristically positive and recurrence is common following subsequent pregnancies. So important to monitor subsequent pregnancies. Symptomatic hypothyroidism should be treated with thyroxine, which should not be required for more than 6 months unless the patient develops permanent hypothyroidism. Thyroid ultrasound may be useful in the evaluation of a thyroid nodule, but it's not indicated in the evaluation of thyroiditis. It just doesn't help in our knowledge of what to do. And subacute thyroiditis is a painful inflammation of the thyroid that is often described following an upper respiratory infection or viral infection, so not associated with postpartum. On to our next question, question 2. A 28-year-old woman comes to establish care. She has a long history of oligomenorrhea and hirsutism and was diagnosed with polycystic ovary syndrome. Her last menstrual period was 4 months ago, which is not unusual for her, and she takes no medications. On physical exam, her weight is 160, a height of 5'3", blood pressure is normal. You note slight terminal hair growth on the mustache and sideburns, above her umbilicus and around her nipples. Pelvic exam is somewhat limited by body habitus, but appears to be within normal limits. Her records indicate in prior testing normal prolactin and thyroid levels, normal levels of fasting 17-hydroxyprogesterone, and a slightly elevated total testosterone level. So, about this patient, all of the following are true except this condition is associated with an increased risk for glucose intolerance or diabetes. Risk for endometrial hyperplasia or cancer is increased. The finding of polycystic ovaries on pelvic ultrasound is highly sensitive and specific for the diagnosis. Luteinizing hormone levels are not required to make the diagnosis. All of the following are true except which one of these? Oh, one more, sorry. Spironolactone may be useful in treatment of associated hirsutism. So all of these are true except one. Select the one that is false. And the correct answer is that the finding of polycystic ovaries on pelvic ultrasound is not highly sensitive or specific for the diagnosis. So that's the false one here. All of the other statements are true, and we'll review PCOS just briefly. So PCOS is a diagnosis of exclusion and is clinically diagnosed by a combination of chronic anovulation and androgenic excess not explained by another endocrine disorder. Those things to rule out include late onset congenital adrenal hyperplasia, hyperprolactinemia, or an androgen secreting tumor. And her labs had shown us that none of those were the case. Although a polycystic appearance of the ovaries is generally present, this has also been identified in up to a quarter of women without other features of PCOS. So it is not very specific, and thus it is not considered either sufficient or necessary for the diagnosis. LH levels are typically elevated with an increased LH to FSH ratio, but it is not necessary for the diagnosis and need not be routinely measured. That's really a change from sort of what was historically considered. A clear association has been observed between PCOS and insulin resistance, and there's an increased prevalence of glucose intolerance and diabetes in women with PCOS, even independent of associated obesity. And obesity is common among PCOS patients, but not always present in affected women. So you can have a normal BMI and still have PCOS. And women with PCOS also have increased risk for endometrial hyperplasia and cancer and should be monitored accordingly. Question 3. A 48-year-old woman reports irregular menstrual cycles for the past year. Her last period was 9 weeks ago. She's had hot flashes for the past 2 years affecting sleep, no significant past medical history, and no family history of blood clots or breast cancer. She currently takes no medications, and her physical exam is unremarkable. Her blood pressure is normal, and she has a normal pelvic exam and breast exam. Which of the following statements is false? So all but one are true. Choose the one that is false. A follicle-stimulating hormone level should be checked to confirm menopause. Low-dose hormone therapy could be considered. A history of deep venous thrombosis would be a contraindication to the use of postmenopausal hormone therapy. Combined therapy with low-dose estrogen and progestin would be preferable to an estrogen-only regimen. So which of these statements is false? So all of these statements are true, except for the first one. A follicle-stimulating hormone level, FSH, is not needed to confirm menopause and therefore should not be checked. And we'll just go through management of this patient briefly. So menopause is strictly defined as cessation of menses for 12 or more months, but menopausal symptoms and changes in the menstrual cycle often begin well before menses cease. A high FSH is characteristic of menopause, but checking FSH levels is not indicated routinely. FSH levels are an unreliable indicator of impending menopause in perimenopausal women. Postmenopausal hormone therapy is very useful for managing hot flushes and vasomotor symptoms. And in a woman with an intact uterus who has not had a hysterectomy, estrogen therapy should always be accompanied by progestin therapy to prevent the development of endometrial hyperplasia and risk of cancer, uterine cancer. When postmenopausal hormone therapy is used, short-term use is generally recommended rather than indefinite use. And contraindications to hormone therapy include venous thromboembolism, history of breast cancer, coronary heart disease, unexplained vaginal bleeding, and active liver disease. So this patient, after her encounter with you, decides at first to take nothing for her symptoms, but returns a year later. At that time, she has persistent hot flashes and has had no menses for the past 6 months. She's interested in postmenopausal hormone therapy because she's really quite miserable with her vasomotor symptoms. Her physical exam, again, is normal. Her mammogram is negative, and we might recall that she has no family history of breast cancer or thrombotic disease. Which of these would be the next thing to consider? Oral hormone therapy is associated with increased risk for gallstones. Which of these is true? Or oral hormone therapy increases the risk for deep venous thrombosis and pulmonary embolism. Progestins may have negative effects on mood. Vaginal bleeding is rare after the first 3 months on combined hormone therapy, or oral hormone therapy increases the risk for stroke. Which of these is a false statement? All of these statements are true except for D, which is that vaginal bleeding is rare after the first 3 months on combined hormone replacement therapy using a combined dose every day. And that's because this patient was just 6 months since her last period. So she's in the menopausal transition and combined daily therapy has a high risk of breakthrough bleeding. All of these other statements are true, and we'll go through those details. So all patients who are considering treatment for vasomotor symptoms should be educated regarding potential adverse effects of hormone therapy. Estrogen, most commonly associated with nausea, headache, heavy bleeding, whereas progestins may have adverse effects on mood and cause breast tenderness. In postmenopausal hormone therapy replacement doses, the dose is lower than oral contraceptives, and usually these side effects are relatively low. However, bleeding is common on a combined estrogen and progestin therapy. On a cyclic regimen, it's predictable, whereas on a daily combined regimen, unpredictable intermittent bleeding is very common in the first several months of use, and it's generally not recommended unless someone is really quite some time since menopause. Oral combined equine estrogen, conjugated equine estrogen, and medroxyprogesterone, which was used in the WHI, was associated with increased risk of DVT, pulmonary embolism, stroke, breast cancer, gallstones, and dementia. But this was among women who were on average age 67 at starting therapy. Overall, transdermal hormone therapy may have lower risk for thrombosis and gallstones. The WHI also showed increased coronary events after the combined therapy in the WHI, as well as in randomized trials of secondary prevention, as well as in the WHI, where women generally had no history of heart disease. And so it should never be used to prevent heart disease. And postmenopausal hormone therapy is indicated and FDA approved for the treatment of vasomotor symptoms, but not for the prevention of cardiovascular disease. Some of the ad hoc analyses for the WHI show no increased risk among women who were younger, so close to the age of menopause, age 50 to 59 when they started the hormone therapy in the trials, but that really wasn't the primary analysis. So we would definitely recommend a cyclic regimen when we were considering hormone therapy for this patient, and to keep thrombotic risk at its lowest, I would usually prefer a transdermal preparation. Our next patient is a 24-year-old woman who complains of irregular menstrual cycles. She reports a 30-pound weight gain over the past 3 years, which she has attributed to a sedentary job. She takes no medications, and her physical exam shows a weight of 180 pounds, height of 5'6", mild hirsutism and acne on the face and back. Abdomen is obese with pale striae. Which of the following conditions is inconsistent with this presentation? So which one is not what we're describing? Late onset congenital adrenal hyperplasia, polycystic ovary syndrome, Cushing syndrome, Turner syndrome, or an androgen secreting tumor. And as you'll see, really these symptoms could be present with any of the following conditions except for Turner syndrome, and we'll review just briefly why. This patient has symptoms and signs consistent with an androgen excess, acne, hirsutism, and irregular menstrual cycles. Possible causes of androgen excess include polycystic ovary syndrome, late onset congenital adrenal hyperplasia, Cushing syndrome, and an androgen secreting tumor. Turner syndrome, an exokaryotype, is a cause of primary amenorrhea and is associated with other characteristic features, including short stature, failure to develop secondary sexual characteristics, and somatic abnormalities such as webbed neck and shield-like chest. androgen excess is not a feature of Turner syndrome. So we could consider and should consider all of the other diagnoses listed in the second bullet, except for Turner syndrome in this case. A 62-year-old woman comes to establish primary care. She completed menopause at age 52. She has never used hormone therapy. She has a history of a right tibia fracture while skiing 10 years ago, so at age 52, and has a history of hypertension. Her only current medication is hydrochlorothiazide, 25 milligrams daily. She smokes cigarettes, about a half a pack a day, does not drink alcohol, and swims regularly for exercise. She has no family history of hip fracture. And on physical exam, her weight is 114 pounds, her height is 5'4", and her blood pressure is 128/80. The rest of her exam is unremarkable. Which of the following is not a risk factor for osteoporosis in this woman that we've just seen? Postmenopausal status, cigarette smoking, her weight, her prior fracture, use of hydrochlorothiazide. So which of these is not a risk factor for osteoporosis? And the correct answer is all of these are true except for the use of hydrochlorothiazide, which actually, owing to effects on calcium metabolism, has a slight beneficial effect. So just to review, risk factors for osteoporosis include age, estrogen deficiency, cigarette smoking, lean body habitus, personal history of fracture, family history of osteoporosis in a first-degree relative, excessive alcohol intake, physical inactivity, Caucasian race, and inadequate intake of calcium. A history of dementia, falls, or frailty also increases fracture risk. And some medications, particularly glucocorticoids and aromatase inhibitors, increase the risk for osteoporosis, but hydrochlorothiazide, through its reduction on urinary calcium excretion, has actually been associated with reduced fracture risk. A nice choice for protecting bones in postmenopausal women. All of the following statements are true except for the following in the management of this patient. Which one is false? She should consume 1,200 milligrams of calcium daily. Drinking 2 cups of milk daily will give her adequate vitamin D. Weight-bearing exercise is recommended. Calcium carbonate supplements should be taken with meals. Swimming would not be expected to increase her bone density. Which of these is false? And the correct answer is that all of these are true, except that 2 cups of milk a day will not give her adequate vitamin D. So the statement is not true as written. So we'll just review a little bit the approaches for treating someone to optimize bone health. And these include adequate intake of calcium, 1,200 milligrams recommended daily in a postmenopausal woman, and vitamin D intake of 400 to 800 international units daily. While vitamin D is added to milk, it's only 100 international units per 8-ounce serving, and so she would only get 200 from her milk intake. Calcium carbonate is somewhat reportedly better absorbed with meals. In contrast, calcium citrate, Citracal, can be taken anytime, and that is also recommended if a patient is taking a proton pump inhibitor. It tends to be better tolerated for some women, but is also somewhat more expensive. As mentioned, the vitamin D in milk, 2 servings would not be adequate, but a standard multivitamin will provide 400 international units of vitamin D daily. And weight-bearing exercise is recommended due to its direct effects on bone. Swimming is great cardiovascular activity, kind to the joints, but is not associated with an increase in bone density. Weight lifting or other weight-bearing exercise, such as walking or jogging, would all be recommended forms. Question 8. For this same patient, her bone density of the spine shows a T-score of -2.6 and a Z-score of -1.1. Which of the following statements is incorrect? So which is not true? She has osteoporosis. Osteoarthritis of the spine could falsely increase her bone density. Her Z-score compares her to normal young women. bone density, bone mineral density is the single best predictor of fracture. Which of these is incorrect? And this Z-score would not suggest the need for a workup of secondary causes of osteoporosis. Which of these statements is incorrect? So the incorrect answer is that her Z-score compares her to young, normal women. That's the T-score. Her Z-score is comparing her to others of her age and race ethnicity. And we'll just review these other points. So the T-score in a bone density reports a comparison with peak bone, or that bone density of young, normal women. The Z-score represents a comparison with age-matched women, so compared to those her own age. Thus, the T-score is used to make the diagnosis of osteopenia or osteoporosis. A T-score between -1 and -2.5 standard deviations below peak is considered osteopenia, while osteoporosis is defined as a T-score less than 2 or more than -2.5 standard deviations below peak. The Z-score below 2, a -2 or larger negative score, suggests bone loss out of proportion for age, and that may be used to identify women who are likely to have secondary causes of osteoporosis, so greater bone loss than suggested for average for that age. Osteophytes or a compression fracture in the spine may falsely elevate bone density readings, and in normal practice, such areas should be deleted from bone density analysis. Question 9. Which of the following statements is true regarding anti-resorptive therapy for osteoporosis? Raloxifene therapy would be expected both to improve bone density and to reduce hot flashes. Estrogen therapy is considered first-line treatment for osteoporosis. Neither alendronate or risedronate may be taken with food. Raloxifene does not increase risk for blood clots. Routine dental work should be deferred in patients taking bisphosphonates. Which of these statements is true? And the correct answer is that neither alendronate nor risedronate may be taken with food. And we'll go through each of the following other statements and talk about anti-resorptive therapy. So postmenopausal estrogen therapy does reduce the risk of fracture, but due to risks associated with long-term use, is not recommended as a standard therapy for osteoporosis. So while if we were using it for another condition, another set of symptoms, it might have a positive effect on bone, it is not a first-line therapy for osteoporosis. Raloxifene, which is a SERM, a selective estrogen receptor modulator, reduces the risk of vertebral fractures, but not hip fractures. And it may actually worsen hot flashes as well as increase the risk for DVT and PE. So again, not a first-line therapy in most cases. Oral bisphosphonates should always be taken on an empty stomach, first thing in the morning, 30 minutes prior to eating, to facilitate absorption, and the patient should be instructed to remain upright after for at least 30 minutes in order to reduce esophageal symptoms. Osteonecrosis of the jaw has been reported among patients taking bisphosphonates. Most of these reports are in patients using high doses intravenously for metastatic bone disease, although they can be reported in osteoporotic patients. And routine dental care should not be withheld in patients taking bisphosphonates. We also discussed the atypical femur fractures among long-term bisphosphonate use, but those fractures are of lower incidence than osteoporotic fractures. A 48-year-old woman who has been your patient for several years complains of constipation and abdominal pain. She has seen 2 outside gastroenterologists in the past year. She's had quite a thorough workup with colonoscopy, barium enema, endoscopy, and abdominal CT, all negative. She's otherwise healthy, except for a fracture of the radius from a fall down the stairs the preceding year. She's married without any children. And her physical exam is remarkable only for ecchymoses on the back and right arm. What might be the most appropriate next step? Repeat a colonoscopy at your institution. Ask her whether she has ever been hurt or threatened in her relationship. Ask her generally about how she is doing, but avoid directly asking about domestic violence. Call her husband and discuss the situation with him. And the correct answer is to ask her and all of your patients whether she has ever been hurt or threatened in her relationship. The possibility of interpersonal violence should be considered in all women, regardless of background, regardless of race, ethnicity, regardless of socioeconomic status. It can happen to anyone. Gastrointestinal complaints are common in women who have experienced trauma and interpersonal violence, as are many other symptoms, but GI complaints are quite frequent. Unexplained fractures or bruising are more obvious clues, but often there are no outward signs, and it's important to consider that abuse may be psychological rather than physical. As mentioned, it's recommended that all women be screened with a straightforward question asking about any history of being hurt or threatened, and then to use that information in a trauma-informed way to help care for them. Question 11. A 37-year-old woman comes for evaluation of a lump she discovered in the left breast 1 month earlier. She's G1-P1 with a menarche at age 14 and regular menses. Her last menstrual period occurred 1 week ago. She drinks 4 cups of coffee daily, and her family history is negative for breast cancer. Her mother has fibrocystic breast disease. On physical exam, she appears well and has a 1.5 centimeter mass palpable in the upper outer quadrant of the left breast, which is slightly tender to palpation. There's no axillary adenopathy, no nipple discharge. Her mammogram is negative. Which of the following would be the appropriate next step? Identify one. Reassure her no intervention is indicated. Schedule a repeat mammogram in 4 to 6 months. Tell her to stop coffee, other caffeine intake, and return in 4 to 6 months for a re-examination. Order an ultrasound. If this is negative, no further workup is required. Order an ultrasound. Referral should be made for biopsy unless the lump is consistent with a simple cyst. Choose the appropriate next step. The correct answer is E, that you should order an ultrasound and referral should be made for biopsy unless the lump is consistent with a simple cyst, and we'll review why. A palpable breast mass requires further evaluation regardless of the patient age or mammogram results. So regardless of her age and having a negative mammogram, it requires further evaluation. Although coffee has been associated with fibrocystic breast disease, a palpable, discrete mass should not be attributed to fibrocystic breast disease or other benign etiologies without the appropriate workup. Ultrasound would be the next step, because if there were a simple cyst, that would be an explanation, but otherwise, biopsy would be indicated for anything other than a simple cyst in this woman. So if a mass is seen on ultrasound or it's not a simple cyst, she would be referred for excisional biopsy. Question 12. A 30-year-old G0-P0 with a 10-year history of type 1 diabetes is interested in becoming pregnant. She has a history of non-proliferative retinopathy with her last eye exam 2 years ago. She checks her blood sugars once daily, and her current medications are NPH 15 units twice daily, Lispro with meals, and a prenatal vitamin. Her blood pressure is 124/80, and the rest of her exam is unremarkable. Her labs show a hemoglobin A1C of 9.0, a creatinine of 1.3, with trace protein on urine dipstick. All of the following would be recommended prior to conception except for one. Choose the one that is not true. An angiotensin-converting enzyme inhibitor should be started to minimize progression of renal disease in pregnancy. She should increase her frequency of blood sugar monitoring. She should be referred to ophthalmology. Blood sugar control should be tightened to achieve a normal hemoglobin A1C. she should have a prescription for glucagon. Choose the one that is false. And the false answer is that she should start an ACE inhibitor, which, while very important if she were not considering becoming pregnant to minimize progression of renal disease, is completely contraindicated for someone who is trying to conceive or could become pregnant. All of the others are true, and we'll review. So tight glycemic control is recommended prior to conception in women with diabetes. The risk of congenital anomalies increases with high first trimester hemoglobin A1C levels. So would very much like to avoid that. The target hemoglobin A1C entering pregnancy should be near 6, so much tighter than our average goal of 7, and she was at 9. Eyes should be checked prior to pregnancy as proliferative retinopathy may progress during pregnancy. Hypoglycemia is common in the first trimester, and women should be aware of symptoms and treatment of hypoglycemia appropriately and should definitely have glucagon available. Angiotensin-converting enzyme inhibitors and ARBs are contraindicated in pregnancy. Use in the first trimester has been associated with major congenital anomalies, and use in second and third trimester associated with oligohydramnios, intrauterine growth retardation, anuria, renal failure, and death, so to be avoided at all costs. Question 13. A routine pap smear at a 42-year-old woman shows atypical cells. She's in a monogamous relationship and has had a normal pap smear in previous years. Which of the following would be most appropriate? Treat empirically with doxycycline and repeat pap in 3 months. It's a normal finding in a perimenopausal woman and does not require follow-up. Endometrial sampling should be done to exclude endometrial cancer. Perform human papillomavirus testing for high-risk subtypes. Which of these is the next step? And the correct answer is that she should have human papillomavirus testing for high-risk subtypes as a next step in follow-up of her atypical cells. So atypical cells are a common finding on pap smears, sometimes atypical cells of undetermined significance or other types. Bacterial infection is sometimes an underlying cause of atypical cells and should be treated if there's good reason to suspect this, such as symptoms, but in an asymptomatic low-risk woman should not be treated empirically. HPV screening for high-risk subtypes is indicated whenever atypical cells are found, often included even in the initial screen, and when positive for HPV high-risk subtypes with atypical cells, colposcopy is indicated. Question 14. We have a 32-year-old woman who is G1P0 and is 16 weeks pregnant. Her current symptoms include palpitations and weight loss. Her physical exam is notable for a pulse of 110. She has lid lag, but no appreciable exophthalmos. The thyroid gland is symmetrically enlarged to about 1.5 times normal size. Her TSH is less than 0.05, and her T4 is 22. Which of the following is incorrect? Which is not true? A PTU can be used in the first trimester of pregnancy. A thyroid uptake should be performed to confirm the diagnosis. A beta blocker could be used for symptoms. Thyroid stimulating immunoglobulin would likely be elevated, or this condition is likely to improve with treatment over the course of pregnancy. Pick the one that is not true. And the correct answer is that we should not perform a thyroid uptake to confirm this diagnosis, and we'll review briefly. So this presentation is most consistent with Graves' disease, which may present early in pregnancy. Thyroid stimulating immunoglobulins, TSI, are typically detectable but need not be checked clinically. If anti-thyroid drug is needed in the first trimester, PTU is considered the preferred drug, as methimazole is associated with a rare scalp defect, aplasia cutis. Outside of the first trimester, methimazole is the preferred drug, given reports of liver toxicity and liver failure associated with PTU. And the minimal dose necessary to keep T4 levels in the upper normal or slightly above the normal range is recommended to minimize drug exposure to the fetus, since this crosses the placenta. Beta blockers can be used for symptom control in pregnancy, such as the palpitations with which she presented. And thyroid uptake testing or treatment with radioactive iodine is strictly contraindicated in pregnancy, as you would not want to expose the fetus to radioactive iodine. The disease tends to remit with treatment over pregnancy, and thyroid function should be very closely followed to avoid over-treatment. So checking frequent TSH and thyroid studies. Question 15, a 22-year-old woman comes for contraceptive counseling. All of the following are true except for which of the following? The risks associated with use of oral contraceptives outweigh the benefits for women with a history of coronary heart disease or stroke. OCP use is associated with a reduced risk of ovarian cancer. Women who are at average risk of STDs without current cervicitis are considered appropriate candidates for current IUDs. Current users of OCPs have a threefold increase in breast cancer risk. And the correct answer, the statement that is not true, is that current users of OCPs have a threefold increased risk of breast cancer. While there is a marginally increased risk, it is much more modest than that. So risks of OCPs include deep venous thrombosis and pulmonary embolism, even with low-dose preparations in the oral form. The risk is reported to be higher with OCPs containing the progestins of desogestrel or levonorgestrel, but can occur with any of them. Myocardial infarction and stroke are rare risks. The risk is higher in women who smoke and those who have uncontrolled hypertension or migraine with aura. And in those women, we would consider that a relative contraindication, or certainly would try to avoid estrogen in the contraception. A history of cardiovascular disease is a contraindication to use of combined OCPs with both estrogen and progestin. OCP users have been reported to have lower risk of ovarian cancer due to its effects on suppressing ovulation, theoretically. Current OCPs have been associated with the small, about a 20% or a hazard ratio of 1.2 increased risk of breast cancer. And long-acting reversible contraceptives, LARCs, are highly effective. Their use is associated with reduced risk of unintended pregnancy and a better reduction in that risk compared to short-acting methods. And most women are eligible for IUDs, except for those who have cervicitis at the time of insertion. Question 16. You're paged by a 32-year-old woman who is worried about pregnancy after having had unprotected intercourse 36 hours ago. Her last menstrual period was 16 days ago. Which of the following is true? Low estrogen with a 25 microgram of estrogen, 2 now and 2 more in 12 hours, is appropriate for use as an emergency contraception. Levonorgestrel 1.5 milligrams as a single dose is appropriate for use as emergency contraception. It's too late to use emergency contraception, or emergency contraception is not warranted at this time in the cycle, which is true. And the correct answer is that levonorgestrel 1.5 milligrams as a single dose is appropriate for use as emergency contraception and would be one of the forms of recommended treatment for this patient. So emergency contraception reduces the rate of pregnancy when given within 72 to even up to 120 hours after unprotected intercourse. Effective emergency contraception therapies include ELA, which is ulipristal acetate, levonorgestrel, the 1.5 milligram single dose, which is Plan B or one step, My Way, also can be quite reasonable, as low as $15. Levonorgestrel is available without a prescription, although a prescription is needed for ulipristal acetate. Intercourse during the luteal phase based on last menstrual period does not rule out possible pregnancy, and emergency contraception is still appropriate in this setting. Although the effectiveness of emergency contraception falls with increasing time after intercourse, it's still reasonable to use within 5 days of unprotected intercourse. Question 17. Which of the following strategies is consistent with current guidelines for cervical cancer screening? Pap testing alone every 3 years if testing is normal in a woman in her 40s. Combined Pap and HPV testing every 5 years following a normal test starting at age 21. pap testing annually starting at age 18 in sexually active women, or no screening in women who have had HPV vaccine, which is an accurate recommendation for cervical cancer screening. And the correct answer is pap testing alone every 3 years if testing is normal in a woman in her 40s. So just to remind you, pap smears are not recommended starting recommended before age 21. So they're to start at age 21, but not before. For average risk women among the ages of 21 to 29, pap smears are recommended every 3 years if normal, and no HPV is recommended for screening purposes. So HPV screening is not indicated in this group. After age 30, it's recommended to screen with pap and HPV screening every 5 years, which is preferred and my usual practice, or a pap smear every 3 years if normal, and if abnormal, then HPV screening. Age 65 and older are currently not recommended for pap smears if they've had 3 consecutive normal pap tests or greater than 2 consecutive negative pap and HPV tests in the past 10 years or within the past 5 years, or they've had a hysterectomy for benign disease. And these recommendations are for average risk women, do not apply to high risk women. Screening recommendations are not altered by a history of HPV vaccine. So you've almost made it through. We're up to our last question. Question 18. A 35-year-old woman presents for her initial primary care visit. Her past medical history is only notable for gestational diabetes during her pregnancy 3 years ago. At her 6-week postpartum visit, she completed an oral glucose tolerance test and was told that her diabetes in pregnancy had completely resolved. She has not seen another physician since her delivery 3 years ago. Which of the following statements is true? Gestational diabetes is unlikely to recur in a subsequent pregnancy. Since she has a normal postpartum OGTT, her risk for developing diabetes in the future is no higher than that of a woman whose pregnancy was not complicated by GDM. She is at increased risk for developing type 2 diabetes compared with the general population. Or sulfonylureas are recommended to reduce future risk of diabetes. Which of these is true? And the correct answer is that she is at increased risk for developing type 2 diabetes compared with the general population. And we'll just briefly review GDM. So women with a history of gestational diabetes, those who have had 2 abnormal values on an OGTT performed between 24 and 28 weeks of gestation often have normal glucose levels after delivery, though they should be screened after delivery to be sure that they have returned to normal. And ideally, they should complete a 75-gram OGTT 6 to 12 weeks postpartum to assist for persistent glucose abnormalities such as impaired fasting glucose, impaired glucose tolerance, or overt diabetes. Even with a normal postpartum OGTT, women with gestational diabetes have increased risk for progressing to prediabetes or overt diabetes. Glycemic status should be monitored long-term in these women by periodic assessment of fasting blood sugar, hemoglobin A1C, or oral glucose tolerance testing. At a minimum, they should be monitored every 3 years by one of these modalities. And annual screening is recommended among women who have impaired fasting glucose or impaired glucose tolerance with a history of GDM. Based on data from the Diabetes Prevention Program, lifestyle modifications, specifically weight loss and increased physical activity, as well as metformin, are effective in preventing progression to diabetes in the future, but sulfonylureas are not indicated for diabetes prevention. That's the end of our time together. I wish you all the best. Good luck if you're taking the exam. Thanks for spending time with us.